Dr. Phillip Whitehead up first from the University of Newcastle, who's going to be talking to us about his use of the ASCOT in his bath out studies, bath out 1 and 2. And then we're going to be listening to Dr. Katharine Orellana from King's College London, who is going to be talking to us about her use of ASCOT in her evaluation of day services for older people. And we will have each speaker one straight after the other. As you're listening, if you've got questions for our speakers, please do type them into the chat, which you can see if you hover on the bottom of your screen. You can see a little box that says chat. If you click on that, the chat box will open and you can type your questions in, and I will keep an eye on the questions and the comments in the chat as we go along. And then once our two speakers have finished their sessions, we will stop recording. We will open it back up to gallery view, and at that point we'll invite you to turn your cameras back on. And I will either select people from the chat to ask their questions, or you can raise your hand at that point, and I can show you how to do that if you're not sure when we get to that point. I know that everyone's probably really used to using Zoom and Teams and things now, but all of these different software are different from one another, and I don't know about you, but every time it's useful to have a little reminder. Okay, so I can see people are still entering, but just for the sake of time, I think we will make a start. So Lizzie, if you can remove the spotlight on me and pop it onto Philip. And Philip, if you're ready to start sharing your screen, over to you.
Thanks very much, Anne-Marie. Hopefully you can all hear me and see my slides. Yeah, great. So I'm really delighted to be here today. I love talking about bath out. If you know me, you'll know that. And also, if you have read, or if you are inclined to read any of the studies that I'm going to talk about today, you will know that I also heart ASCOT too. And I'm not just saying that for the event and for the audience. I really do believe that it is an important measure for this population and this intervention. And hopefully in the next 20 minutes or so, you'll see why. So Bath Out is funded by the National Institute for Health and Care Research, the School for Social Care Research, and I'm really grateful to the support that the school has shown to the study and to my career over several years. Notwithstanding, they're not willing to accept responsibility for anything that I'm going to say to you in the next 20 minutes. So just a little bit about me, for those of you who don't know me. As Anne-Marie says, I'm at Newcastle University at the moment. I'm on one of their in-house academic tenure track research fellowships. And I had a career in social care as a home care worker first, and then as an occupational therapist, and a brief spell as an occupational therapy team manager. And in research, I had a doctoral research fellowship and a clinical trials fellowship, which both had social care focus, and I'm probably quite unique in terms of a person doing trials in social care, and you'll hear a bit more about that in relation to Bath Out and ASCOT. And the things that I'm interested in most in terms of my work are prevention linked to occupational therapy and social care, and the fields of home care and housing. So just before we start, I'm really guilty of just talking about bathing adaptations and assuming that everybody knows what we mean. In the context of Bath Out, it's a major adaptation that we're interested in, which is usually the removal of a bath and the replacement with a level access shower of the type that you can see here. It might be the removal of a shower cubicle or something also inaccessible. And it may come with rails that you can see, or a piece of equipment like a shower chair. The route to the major adaptations via statutory services is usually via an occupational therapy-led assessment within social care to determine if the adaptation is necessary and appropriate. And then the occupational therapists usually work in conjunction with housing to carry out the adaptation. So that's the intervention that I'm talking about here. So I'm going to start by talking about our qualitative study before I move on to the evaluation. which might seem a bit odd because that's what I was asked to talk about, the evaluation, but the qual work really sets the scene for why this is an important measure to use in the evaluation. So this work was with 21 older adults and 5 carers of older adults, and they were a subset of the participants in the BATH-OUT-1 study, which you'll hear about next. And you're probably all familiar with the 8 domains of the ASCOT. I'm just going to reorder them here for the purpose of saying to you that that top line, those 3 at the top, directly map onto 3 of our themes in the qual work that we did. So I'm going to talk to you about those. The 3 on the next line didn't directly map, but we saw elements of these. And the bottom 2, not so much in the context of the bathing adaptations. And I'm not going to present the qual analysis sort of in full or in any sort of robust presentation way. What I'm going to do is give you an illustrative quotation for each of those top 3 to show the importance of the measure to this intervention. So the first one on the theme of feeling safe, this participant was speaking after he'd had his major adaptation. He'd got his new shower installed, and he was talking about that in comparison to his previous situation, which was an overbath shower. So he had to climb into the bath to use that shower. And he said it was more tense. It was more like you're going into a campaign, by which he means a military campaign, saying you're going in now, look out, you're aware, you've got to be careful because one slip and you're going to hurt yourself. And he was doing this without any sort of overt sense of hyperbole. He was just describing how it was. And it's one of my favorite quotations because I think it really illustrates the impact of an unsafe environment within one's home and how that can feel. So the next one on feeling clean, I feel a little bit embarrassed about how lazy this is in terms of qual analysis. Feeling clean, it seems really obvious in terms of that's the purpose of the adaptation. But I think this quotation really shows the importance of feeling clean and kind of your wider well-being or quality of life. Again, this was a male participant, and he said before he had his adaptation, it used to get him down because he couldn't have a proper wash. He used to wash himself and still sit, and you think he didn't feel clean. And now he feels a hell of a lot better. He feels as though he's clean and he's not sniffing under his arms, concerned that he's got body odor. So like I say, I think it's easy to take for granted when you're able to keep yourself clean, how that makes you feel much more broadly. And the final one on choice and control, this is my favorite quotation from the whole data set, again, illustrating the link between control, the adaptation and wider quality of life. This participant was a lady, and she said, it's changed my life completely from not feeling as though I'm in control, which I've been in control all of my life. And for the last few years, I've had no control. I've got to wait for someone else and I've got to sit. I can't have a shower when I want one. And her situation was that because of the risk of using the bath, she didn't have a formal care arrangement. She was relying on a neighbour to come and be in the property with her when she needed to use the bath. And I think she really illustrates how the impact of that on her choice and control in her wider life, and how that had changed following the installation of the adaptations, because now she can wash her whole body without any risk and not having to wait for people to come in. So that's a very sort of whistle-stop down and dirty, quick run through those key domains of the ASCOT, which I think link to the bathing adaptations. So BATH-OUT-1 then was a feasibility study, feasibility randomized controlled trial. And the purpose of that was in response to a systematic review, which said that we need further randomized controlled trials of major housing adaptations. because there's a real lack of them, it's very difficult to conduct a randomized control trial in this setting because, as I explained, the purpose is via a social care-led occupational therapy assessment. So we don't know that someone is eligible for it until they've had that assessment. And once they've had the assessment, we can't really withhold it to form a control group. So what BATH-OUT-1 was trying to do was to say, is it feasible to use routine waiting times within statutory services to form our control group and conduct a trial? And as part of that, we had a series of secondary objectives, and one of those was around identifying suitable and sensitive outcome measures to use in that study. And obviously that's the link to ASCOT. So what happened in BATH-OUT-1 was consenting participants had a baseline assessment, which included ASCOT, and they were then randomly allocated 50-50 or 1-to-1 ratio to the usual care, which in BATH-OUT-1 site was a 3 to 4 month wait, or to an alternative rapid or expedited adaptation, where the aim was to get that done straight away and for it to be in within 3 months. We then followed up both groups at 3, 6 and 9 months. So the idea that at the 3-month follow-up, rapid group have got their adaptation and are using it, and control group are still waiting. And at 6 and 9 months, control group, well, both groups have got their adaptations. So this is the ASCOT data from the BATH-OUT-1 study, which included 60 participants. So there were 31 in the intervention rapid group, which is represented by the green line, and 29 in the control group, which is represented by the red line. So they're small numbers, and I'm not presenting this data as being in any way explanatory. It is exploratory around the suitability of the measure to use in this context with this intervention in the way that we are doing. What you can see, though, if you bear in mind that the green group had their adaptation between baseline and 3 months, and the red group had theirs between 3 and 6 months, you can see improvements in both groups after the installation of the adaptations. And that improvement continues. In part, that is because the improvement continues, but it also bear in mind we didn't get all of the adaptations in the timescales. So it also does reflect the fact that there were some additional people that were starting to have their adaptations installed, which is kind of driving those improvements. And again, not seeking to explain anything, but looking for what kind of effect we might be able to see. In BATH-OUT-1, you can see we've got a 4-point increase in the intervention group at 3 months compared to a 1-point reduction in the control group. So that arrow representing that 5-point difference change from baseline intervention to control we saw in BATH-OUT-1. And just for your interest, the clipboard shows the other outcomes that were measured in addition to social care related quality of life alongside that. So then after we completed BATH-OUT-1, we were successful in getting some additional funding to go back and follow the participants again. This was around 18 months after they'd been randomized into the BATH-OUT-1 study. So the participants that we followed again were the ones that we approached were those who took part in the qual interview study. So those 21 of those who had consented to be contacted about follow-up studies, we approached them to take part. And we asked them to do another interview and also to collect the outcome assessments, again, including ASCOT. That's the data that I'm going to show you here. So what you're looking at here is the same chart again, the main study chart, which you saw on the previous page. And then of those 21, there were 13 that agreed to take part in the follow-up study. or that we got the ASCOT data for at 18 months. So again, it's very exploratory, very small numbers, but what you can see here is that that trend of improvement has continued to 18 months and actually quite close to the ideal health state at 18 months, which, considering where they started at baseline, is a nice trajectory. It is worth noting that if you compare the numbers in the table along the bottom, the extended follow-up cohort, they are doing slightly better at all time points than the people in the main study. So it feels reasonable to infer that the people that were willing and available to be followed up were the people that were kind of doing the best. But even so, it's nice to see that that trend has continued. And again, from our interviews, this time the interviews weren't so much focused on those perhaps immediate effects, feeling clean, feeling safe, and choice and control kind of not so much. This time we did see those wider social participation and occupation issues being more of a focus. And again, as this participant says, she's not being shut in the house anymore. She's getting out, meeting people, doing things that she wasn't doing before because of the fear of talking to people, that concern about her personal hygiene. So again, that sort of trajectory into the future does make sense.
You're muted, Philip.
I don't know how I muted myself, sorry. This is just for interest again, rather than being explanatory, but we looked at the mean scores for each domain. So we were thinking about which domain, how had each domain moved over the course of the 18 months for this group of people. And you can see the biggest change was in the occupation domain, but that was the one that was with the lowest score at baseline. And the other thing that I think is quite interesting in this data is personal safety at extended follow-up. All 13 participants scoring 1 ideal health state, so no safety concerns at all in the cohort at the extended follow-up point. So what we've done with all of that work from BATH-OUT 1 is to take that forward into BATH-OUT 2, which is now a definitive powered randomized controlled trial with an embedded economic evaluation and a process evaluation. Again, still funded by School for Social Care Research. That study is in progress at the moment. And like I say, there are those three aspects to it. The randomized controlled trial has a recruitment target of 360 older adults, and we're working across a number of geographical areas in England. We're using in the powered trial what's called pairwise randomization. So the participants are for every pair get randomized, and then we follow them up based on the timescales that the adaptations have been completed, because there's quite a lot of variability around when that happens. And in this study, we're following participants over 12 months. So we'll get quite a lot of data and quite a lot of variability around the times that participants have had their adaptations over that 12-month period. The primary outcomes in the study is physical well-being, the physical component summary of the short form 36, with ASCOT as one of our key secondary outcomes in that. So there's a economic evaluation with the cost effectiveness and cost utility and a return on investment, looking at expedited versus routine provision, and lots around processes within the trial and more widely within social care and housing. And as we're about to go live with a national survey of local authorities, housing adaptations departments as part of that study. So how that's progressing. We've got 5 sites that are signed up and going at the moment, 2 in Yorkshire, 1 in the Midlands and 2 in London, and we're in the process of identifying and opening some more sites now. We're around about 140 recruited and randomised, so well on our way. And I think that's all of my slides. Thank you everybody for listening. That's my email address there. I'm very happy for people to get in touch with me if they'd like to know anything more. Thank you.
Thank you so much, Philip. It's so interesting. I have burning questions, but I think, as I said at the start, what we will do is we will move on to Katharine's just to make sure both speakers have optimum time to share their slides, and then we will bring everybody back together at the end and invite you to put your cameras on and ask questions for both of our speakers. So I'm going to hold my tongue and hand over to Katharine, who's going to share her screen. Thanks, Katharine.
Hey. Hi, everybody. Can you all see? Yeah, can you see the screen?
Yes, we can.
Okay,
perfect.
Good. I'm Katharine Orellana. I work at King's College London. I'm not going to give you a massive update about me, but I am going to give you a whistle-stop tour of my experience of using ASCOT Int 4 during my PhD research with day centre attenders and their carers. So the study was funded by Dunhill Medical Trust. So thank you to them and everybody who supported or participated in it, and also to NIHR's Applied Research Collaboration South London, which currently funds me. And as for Philip, anything in this presentation is purely down to its authors rather than anyone who's funding it. So for a little bit of background first, not everybody knows what a day centre is. For the purposes of this study, day centres for older people are community building-based services that provide care and or health-related services and or activities, specifically for older people who are disabled and or in need, which people can attend for a whole day or part of a day, usually on a planned basis. They can differ in their ownership, target clientele, admission criteria, building used, sized, what they offer, in the way they're funded and in their quality. They're a large out-of-home service used by around 10% of publicly funded older people who don't arrange their own services, half of whom are physically frail or disabled. Those are figures for 2013 to 14. And having said this, COVID has changed the day centre landscape somewhat, but I'm not going to talk about that. There are other older people not known to social services who use day centres too, but nobody knows how many, because day centres are in many respects a bit of a mystery. In England, they're not regulated by the Social Care Service regulatory body, the Care Quality Commission. There's no central record of the ones that exist, and the research evidence is mainly quite old or about people with cognitive impairment, not older people generally, or about specific aspects of day centre provision, but not about, say, day centres as a whole service. So the conflicting perceptions of day centres were described beautifully in an English social care sector magazine article. For some social care professionals and service users alike, day centres offer the ideal opportunity to provide targeted services to clients in a safe, stable environment. But others regard them as outdated and patronising, a service firmly stuck in the last century. So in my view, then, day centres are a bit like Marmite, but most people try Marmite before making a decision about it, whereas people seem happy to make assumptions about day centres, often without any knowledge or evidence about them, as did Andrew Marr in a radio interview. He said, the cliched image, I'm sure, of day centres is that you sit there passively. People bring you things, lukewarm cups of tea and biscuits, and the atmosphere is warm and there might be some nice undemanding music bubbling away in the background, but essentially you're there as a passive pot plant. So people really don't have terribly positive views of day centres. A few decades ago, they was a central part of service provision in England, but they're commonly being closed or decommissioned, particularly those that offer low-level support, despite some older people expressing wish to access them. And day centres have themselves even protested about proposed day centre closures. And there's a very nice video you might like to watch of a protest song here. A colleague did a freedom of information request in 2018, and found that there had been an average funding cut of 30% for day centres over the previous 5 years, and some cuts were up to 55%. So it's important to understand the full range of benefits a day centre may have. So a little bit about study aims and methods. The study aimed to improve the understanding of day centres' purpose and role, how they're viewed and their use. Outcomes contribute hugely to a day centre's purpose and role, so it's important to investigate them. We don't know, do day centres actually support people who attend them and their carers? How do they support them? It is important to understand more about outcomes, especially because of the perceptions that people have of day centres that are not always evidence or knowledge based. I used a multiple embedded case study approach and non-random sampling to recruit. Participants were 4 generalist day centres and 69 individuals, and 3/4 of the 23 attenders used their day centres for only 1 or 2 days a week. I used mixed methods to explore outcomes, experiences, views and perceptions, which involved qualitative interviews and using ASCOT Int 4 with attenders and carers. And today I'm going to focus on ASCOT's contribution to the study's findings and reflecting on its use. So moving swiftly on to the results. With ASCOT Int 4, people rate their need level in each domain with and hypothetically without the service, where nothing else steps in to take its place, if they say it affects their quality of life in that domain. And the difference between these is the impact of the service that you're talking about, the social care related quality of life gain. Here I've put dignity alongside the other 7 domains in the usual graph. It's not included in the graph because people are not asked the hypothetical expected question about it, so it doesn't have 2 scores. The higher out the lines, the higher the quality of life. Blue is attending the day centre, red is hypothetically not attending the day centre where nothing takes its place. On the top left, we have the overall average gain scores. Scores can range from -0.17 to 1, where less than 0 is worse than dead. 0 is the equivalent of being dead, and 1 is an ideal situation. So we can see that the average social care related quality of life gain score for day centre attenders is 0.18. And these scores are preference weighted, which means that greater weight is given to the domains people have reported as most important. Calculations are based on responses to a best-worst scaling approach and a time trade-off exercise tested with non-service using members of the public and service users. So for day centres, for the individual domains, social participation and involvement came top in terms of gain scores. Dignity and meaningful occupation came second. Control over daily life and personal safety came joint third. Food and drink fourth. Personal cleanliness and comfort fifth, and accommodation last with a score of 0. And the results show that with 99% confidence that day centres have a significant impact on their attenders' social participation and involvement and meaningful occupation. And we can also see here that some people said that day centre attendance made a difference to their lives, even in domains that scored 0 or very low. For example, almost a third said it made a difference in the domains of accommodation and personal cleanliness. There's a bit of a possibility that using ASCOT by itself may underestimate the impact of a service if you rely solely on the gain scores, because they miss people who said it made a difference to their lives, which is the filter question. So this slide is now hideously busy, so I'm going to share my preferred layout. I like this bar chart because I think it's clearer, more comprehensive, and it includes dignity. And I think the negative and positive psychological impact of support and care on personal sense of significance is far too important to leave out, even although the spider graph is really pretty. So we have pale and dark grey showing expected and current scores. Note that the expected score for dignity is the centrally calculated broader level 1, not for this group of people because there's no filter question. As before, red is the average gain score for each domain. Blue is the number of people saying attending made a difference to their life in that domain. And I'll just give you a quick taster of the qualitative themes, although I'm not talking about these either. I asked about experiences of attending a day centre, if doing so added anything to people's lives that they would not otherwise experience, and what were their 2 favourite things. And interestingly, their top 2 favourite things about going to their day centre were also the 2 domains that were those showing statistically significant average gain. Underlined themes were unique to the qualitative data, and there was some overlap with ASCOT in others, but that's not something I can cover today. ASCOT also provides data about levels of need in each domain that are a useful indicator. For example, this chart, the yellow, indicates that if day centres were no longer attended and the service gap wasn't filled, so if they were to be closed, for example, and nothing else was put in its place, the highest unmet needs would be in social participation and involvement and occupation, which were the top 2 favourite ones. Even when attending day centres, some participants still had high needs in the domain of social participation. And people also felt they'd experienced high needs in the domain of control, food and drink, and personal safety without their day centre. So moving on to carers, which the ASCOT Int4 carers, which has a similar structure. There was an overall social care related quality of life gain score of 3.10 that was attributable to carers' relative day centre attendance. Individual scores in this one can range from 0 to 21 and they're not preference rated. There was improvement in all domains, some more than others. Much of the gain was in the higher order domains of feeling supported and encouraged, occupation and control. We had expected higher gain in the space and time to be yourself domain, which came third alongside looking after yourself, because in the qualitative interviews, carers said that having free time was a highly valued outcome, but many carers had other time-consuming responsibilities like partners, children and paid employment. And we thought the contributing factors to the quite low overall gain were that most carers weren't co-resident, few days were spent at the day centres, and most attenders didn't have dementia. In the qualitative interviews, I asked carers what they got out of their relatives' day centre attendance and what they valued most about it. And the themes were mainly wellbeing related, and the numbers of stars here indicate the most valued outcomes. And as for the attenders, there was quite a lot of crossover between some of these with ASCOT themes. So some reflections on ASCOT. I found it to be a really valuable tool that helped me evaluate the impact of day centres, and I feel it considerably enriched the study's findings. I think gathering both the qualitative data and the quantitative data was definitely a strength, as Phillip said for his Bath Out study as well. ASCOT data complemented the qualitative findings by isolating the impact of day centres on the different quality of life domains, whereas the qualitative findings offered more insight into the reasons behind the scores. In the qualitative interviews, almost all the attenders and carers said they had gained something they would not have experienced if not attending their day centre, and this was reflected in the ASCOT data too. And importantly, this for me supported the assertion that day centres are services that are actually relevant to current social care and health policy, because they promote well-being, their attenders have a positive experience of care and they support carers. And this is important given the decommissioning of day centres. I think ASCOT Int4 is an excellent, relatively easy way to quantify service impact in one single interview. It quantified impact for intangible things that would be otherwise difficult to measure, so the higher order outcomes like feelings of being in control, feelings of personal significance, feeling supported and encouraged, which are all hugely important for quality of life. Numbers are also good for people who favour a quantitative approach or who sadly lack faith in the robustness of qualitative research. Using the spreadsheet to calculate scores was like super easy. Having said that, I have to admit that I am not statistically adept, and had I been, I probably would have got a lot more out of the data than I actually did. I thought the multiple layers of impact were fabulous. You had the overall gain by domain, number of people it made a difference to, the level of need and changes to this. Excellent things for evaluating day centres. I also found it interesting to see how scores differed across the 4 day centres. So because it's standard, it enables comparison of impact over time as well, or between services, which may be a good thing or a bad thing, depending on who's doing it and why, but at least it uses fixed wording, so it's as neutral as possible. And the data is also comparable. It can be compared with national level data if the scores are converted. So the ASCOT, as part of the Adult Social Care Outcomes Framework, ASCOF, local authorities do an annual survey that gathers data using the 8-question version of ASCOT about current quality of life. And Int4 current scores are comparable with this if aggregate non-preference weighted scores are calculated. And my data showed average participants score as 19.4, which was favourable compared with the national scores reported in ASCOF for the same period, which were 18.9 across England and 18.95 in the 4 local authority areas of the study. The most important thing for me specifically was that ASCOT Int4 using it with attenders helped counteract some of the historic criticisms of day centres, which are really big. It's not uncommon for these services to be portrayed as an outdated service model that's a poor fit with today's older people's preferences in the environment of personalisation, choice and control. Some people believe that day centres perpetuate social isolation out of normal community life, and day centres have been depicted as partial institutions that create or reinforce dependency and undermine self-identity. Yet ASCOT showed the highest gains in the domains of social participation and involvement, dignity or personal sense of significance, and feeling in control. And the qualitative data also found this. Before attending, participants' restricted mobility had limited their out-of-home activities, so they were already out of normal community life. Attending a day centre enabled them to be part of a specific community in the absence of another option, and therefore replaced some of what had been discontinued in their life. And it was a satisfactory alternative that offered them lots of opportunities in a group environment. And the attenders also reported gaining feelings of independence, control and freedom, and said that they made choices at their day centre. Although some choices were limited, but they still made choices and felt in control. From what they said, it was clear that the power dynamic lay in their hands. So far from disempowering attenders and undermining their identity, attendants actually made unique and positive contributions to most attenders' lives. High proportions said they enjoyed attending them, looked forward to going, and considered they were getting value for money. So it seems that these criticisms, at least for my sample, are not valid. There's always something that doesn't work as well. ASCOT Int 4 is very, very long, has an awful lot of words, but the structure is consistent, which helps. So there are 23 questions, which adds up to 2,444 words for all questions, with a filter question potentially reducing these to 16 questions. Each domain has a question about current service related quality of life, a filter question about does it affect your life, and if yes, a question about hypothetical quality of life in the absence of service. I think the advice has changed now, so you're supposed to ask the hypothetical question even if no is the answer to the filter question. Thinking this was a lot of words, I used an A4 large print show card, well, lots of show cards actually, which really helped almost everyone, including the carers, and particularly people who were hearing impaired. The attenders seemed to appreciate me running my finger under the words as I read them out, and we looked at them together. So average administration time with attenders was 15 minutes, and it ranged from 6 to 33. And I logged this because one of the reasons I was administering ASCOT was to see if it would be a feasible measure of quality of life change, and therefore an outcome measure for day centres to report to local authorities or other funders. The administration year, so it ranged from 6 to 33 minutes. So in a way you could say there was a potential for fatigue given the number of questions and the fact that it was administered after a qualitative interview. But to continue directly after the qualitative interview was every participant's choice. Nobody seemed to be fatigued at all. Even people experiencing difficulty with the questions were very engaged. And the longer time was mainly because some participants enjoyed giving extra detail, or were very deaf, or needed the questions or wording to be explained. For the carers' the version was quite quick, at 7 to 17 minutes with an average of 10, and most carers seem not to have any problems with understanding and answered without hesitation. I also used the show cards with them because I thought it's just too much to remember when you ask a long question. I didn't finish it with one of the attenders who seemed to understand the concept of the questions when I explained it at the beginning, but it became obvious quite quickly she couldn't manage, and this person couldn't read or write, so the show card was no use at all. The wording and meaning was confusing for some. Some attenders struggled to imagine a scenario whereby nobody would step in or organise alternative support to cover the lack of day centre, and this was a major block in their mindset to answers. Some were slightly confused by some of the questions, and there was a certain level of clarification needed before they were happy to answer. So the word affect in the filter questions seemed to have negative connotations for many attenders. So the question was, for example, do the support and services that you get from whatever service affect how much control you have over your daily life? And I think that some attenders may have chosen a different answer to this filter question had the phrase make a difference been used instead. Some people's responses didn't match what they said in their qualitative interview. So, for example, someone said that the day centre felt like a second home, yet they decided that it didn't affect her in various domains. Some moved on quickly and may have been offended if I'd questioned their response or understanding of the question. Others were quite happy to be asked. Some stuck with their first response and some didn't. So because of these things, I think the ASCOT gain scores may potentially have undervalued actual gain for some people, which is why it's also good to report the numbers of people saying yes to the filter question and the levels of need alongside the gain scores. On guidance, there is guidance for administration and for calculating scores, but there's nothing about interpreting gain score, whether it's preference weighted or not. So I was left wondering what it actually means in the bigger scheme of things. Is there anything I can compare these scores to? How do I report it? What do the numbers 1 to 100 in the graphs mean if they're not actually percentages? And I would have liked guidance on further analysis possibilities, but that reflected my own inexperience at the time. It was my first big research project. It was great to be able to calculate whether gain was statistically significant in the various domains though, and Anne-Marie coached me through this super patiently. I also would have liked to have done this for overall gain and individual gain, but my small sample probably wouldn't have allowed those calculations. The last niggle is that dignity is missing from the spider graph, which people use to report. And I understand why, but it seems a shame. And that's why I used bar charts when I was reporting. But despite all these things, I think ASCOT is brilliant and very much worth using. So my wild aspirations for the future, with the background of a national rollout of social prescribing and generalist day centres being most at risk of funding cuts at the same time as increasingly catering for the spillover of people with cognitive impairment and multiple long-term conditions being of interest to lots of people now, my aspirations would be to use ASCOT Int4 to produce larger scale evidence of generalist day centres' impact on quality of life, which is what NHS commissioners may want to know before even considering investing, seeing as they only commission evidence-based services. I'm not sure local authorities would be as interested or have capacity to process locally collected data, but a large study with generic data would be good from that perspective. And to gather cost data to do an economic evaluation using ASCOT would be amazing, but cost data is it's a complex minefield with day centres, and it's very, very hard to get. Older people in my study said they felt like they were getting good value for money, and in my head, cost per hour at a day centre is likely to be less than for home care, which provides personal care to one person for a short time. So it's likely to be good value for money given day centres' broad impact, but it seems that many people class day centres an expensive service, which is an easy saving if you need to do a funding cut from a local authority. If there are any funders out there, please feel free to step forward at this stage. Methodology-wise, it would be very interesting to use an interview schedule that combined the ASCOT questions with the qualitative questions. I read an article by Abinstern and colleagues who wrote about recording conversations during administration of a validated scale, but I think actually mixing up the qualitative and quantitative questions would be fun if that didn't jeopardise the validated scale aspects. And in terms of other tools, a version for use with people with dementia would be very welcome, but I know that's already in hand. And a version for social care staff and volunteers would also be great. With volunteers, that would also support social prescribing and that agenda from the NHS. So that's me finished. Thank you for listening. Here are my contact details and details of the article that reports the ASCOT and qualitative findings about attender outcomes.
Thank you so much, Katharine. What a fascinating and informative presentation. Thank you.